Top Med Talk. Hi, I'm Monty Mython, Editor-in-Chief, live back at Anesthesiology 2018 here in San Francisco, the annual Congress of the American Society of Anesthesiologists. We're at the Smith's Medical booth, that's 1519. Top Med Talk is the broadcasting arm of evidence-based perioperative medicine. I'm sitting here once again with Desiree Chappell, Associate Editor of Top Med Talk, and the US lead for Top Med Talk. Desiree, welcome back. How are you?
Thanks, Monty. I'm great.
Great. Any news? Anything happened in the last 7 minutes since we were on?
Not really. No, not too much. It's just still exciting to be here, and the temperature's changed a little bit. It's a little bit chilly,
So
you know details.
You managed to snag a special guest for us. You mentioned you might be able to swing by earlier today. I think you bumped into Mike Scott from Virginia Commonwealth.
Good morning.
Mike, welcome back.
Hi, thank you.
Mike, a British voice there. I know you extremely well. We know each other for a very long time. But as you're now in Richmond, Virginia, I believe, is that right?
Yes, at VCU.
VCU. So tell us a little bit about where you were working in the UK and when you came over here to the United States.
Yes, so I was working in Guildford, which is the Royal Surrey County Hospital, just outside of London. It was a fantastic unit. It did a lot of elective cancer surgery. And we're known really for running a lot of live courses in both enhanced recovery and in minimally invasive surgery. And we have very good outcome, short lengths of stay, with good 5-year cancer data. And I think it's a great model to show that rapid recovery, provided it's uncomplicated, leads to better downstream results for patients, both not just from cancer but from better functional activity as well. So really we were an ERAS centre based in the UK.
And starting quite a long time away, you were one of our early wave of enhanced recovery adopters in the UK that we then used as a poster child for the rest of the country.
That's right, yes. It started really with the arrival of Professor Tim Rockall, who is a true expert in laparoscopic colorectal surgery and running it through the Minimal Access Training Unit. And we basically realised that we needed to do less invasive things with people having minimally invasive surgery in order to get them better sooner. And so enhanced recovery evolved. And we often show a video back in 2003 of a guy going home after 23 hours, having had a laparoscopic anterior section and TME. And the grainy effect of the video really gives a good idea of just how long we've been doing that for.
So just to be clear, 15 years ago, you were sending patients home in less than 24 hours, having had laparoscopic right hemicolectomys.
Correct, yes.
Because I think you wrote up a series.
We published the series. Well, we actually did an RCT, so we did a prospective series. So we weren't just selecting patients, and we managed to get them all home within 23 hours with good outcomes. And that was published in 2009.
20-40% readmission rate? Come on, they must have been flocking back in through the doors.
No, but they all had good follow-up from our enhanced recovery nurse and the fellow who was conducting the research.
Because when I read it, it read 0% readmission rate.
Well, it was 0%, and we do have still a very low readmission rate back in Guildford.
Now, part of that must have been Tim is extremely well known as a very, very talented surgeon. I mean, right at the sort of Leonardo da Vinci end of the spectrum when it comes to talent. But he's surrounded himself then with an extraordinarily talented team of providers at every step of the pathway, which often tends to happen. Yeah,
I think we built the unit. We appointed more and more anaesthesiologists who'd done fellowships with us, who really truly adopted the principles of enhanced recovery, goal-directed fluid therapy and opioid-free analgesia. The surgical department grew and grew with the emphasis on minimally invasive surgery but also rapid recovery. But what's really impressive is I flew back 4 weeks ago to do a live surgical course. I walked in not having given an anaesthetic in the UK for a year, and it all still works. Oh. All the surgeons are still doing the same thing. The anaesthesiologists are doing the same thing. We walk the patient in the PACU for everyone after a 3.5 hour right hemicolectomy.
Fantastic. And you do the whole gamut of the pathway, whatever people want to debate, the carbohydrate drink all through goal-directed therapy, regional analgesia, multimodal, rapid drink, eat, mobilite. You do the whole 9 yards.
Yes, and basically there's just an ethos in the hospital now, so every patient gets it. So, and I think that's important because when I've been introducing things over here in the US, people say, well, do we need to give carb drinks for day case? And I said, well, you don't really need to, but the importance of the message to both all the nursing staff, everyone in the hospital, is that being starved for surgery is bad. So if you create a a standard of care, it tends to get adopted and is better and gets implemented across most people. Then you get better outcomes.
Hallelujah to that. I mean, one thing I think we learned from the national programme is those sort of mid-sized hospitals, of which Guildford would be one of those. It's not a university hospital, it's a university-associated hospital. They tended to go for that total system adoption, and it worked really, really well, whereas people got over clever in the ivory towers and went for piecemeal adoption. It just dragged out for years.
Yeah, I think that's very interesting, because in the US I've been involved with various different areas and other hospital systems in getting enhanced recovery up and going. And what the win has been in Virginia Commonwealth University is not just empowerment, because the whole of the board have supported me, hence why I got moved across 2 years ago. But we are doing both a vertical implementation and horizontal implementation. So we're fixing pre-operative care, we're fixing the pre-surgical unit, we're fixing what happens in the OR from the point of anaesthesia and surgery, and then the de-escalation post-operatively. And then we're running through the specialties. So what it enables is that you get a system fix, and then all you've got to do is tweak specialty by specialty on whether you're going to take a drain out on day one, or whether there's going to be certain criteria of whether you're going to keep it in or not.
And Desiree, I want to chip on this, and any unique or different challenges coming to the US?
I was just going to ask, what are you seeing as the disconnect? Because obviously there are.
It's a completely different system here. I think just anaesthesia alone has a different role. Often you're meeting the patient day of surgery, and you wave them off in the PACU to basically be looked after by the surgical residents. So the role of the perioperative physician over here is really taken pre-operatively by the cardiologist and post-operatively by the surgeons. So the biggest change I've done is basically create the perioperative system whereby both anaesthesia, surgeon, nursing, the physiotherapy and nutrition have basically a view of the whole pathway. There are elephants in the room, so even in nutrition, where we know pre-operative nutrition is the best intervention to have for outcome after surgery, we have an excellent nutritional team, but there was no pre-operative nutrition. Same with anemia management. We know that anemia is bad going for surgery, and yet the system over here, once a patient gets booked for surgery, there's very little discussion on whether delaying surgery for 2 weeks and optimising the haemoglobin by even just a gram or two to reduce the risk of transfusion may benefit the patient. So there's different challenges, because the priority is to get patients into the hospital for surgery. Whereas in the NHS, we actually have a good time period, because we've got more pressure on our resources, and there is an actual time flow for surgery being 3 to 4 weeks after diagnosis, even for cancer. It does give us that 3 to 4 week window to optimise our patients prior to surgery.
And we'll come back to that in a moment, because I think we're going to talk a bit more about specifically anemia. I think that Desiree, it's one of the reasons you invited Mike, because Mike was talking about it on Friday. But before they do that, you were part of writing the perioperative quality improvement guide. Well, you've been part of writing lots of guidelines for enhanced recovery. Okay, there's two recent recurring questions. One of them relates to ketamine, and one of them relates to gabapentinoids, because when we talk about multimodal, people seem to be very accepting of acetaminophen, paracetamol, non-steroidals. They then talk about non-steroidals and anastomotic leads, etc. Let's park that for a second. There's some people say with the gabapentinoids that the literature is clearer and clearer that they don't help. And I don't see it that way when I read it. What's your view on that?
I think what's important is we have a framework for analgesia, which is procedure-specific and patient-specific. Right. And also we have a framework which starts with education expectation setting, then goes to multimodal, but also we have either single shot or catheter-based technique with local anaesthetic for major surgical cases. I think the evidence with both acetaminophen and non-steroidal is very strong in all of those. Yeah. However, obviously we need to have caveats of when we give them. Obviously, reduce the early use of them if patients are at risk of harm, such as having renal failure. But with gabapentinoids, I think I did some work for the HRQ series of recommendations with Chris Wu. Certain specialties, there is evidence for gabapentinoids. But in others, if you're using non-steroidals with acetaminophen, the evidence base is quite low. So I think, again, I wouldn't want to give a black and white answer. I think gabapentinoids have a role and can be beneficial in certain surgical specialties, but others, they don't seem to always be necessary. And certainly back in the UK, we didn't use gabapentinoids for the last 10 years in my unit, and we didn't have a problem.
And do you have any old age cut-off point?
Yeah, so what we've done in the system, we do use them in the VCU system, and what we've done is create, in Cerner, we have a mechanism whereby, depending what age you are, we either reduce the dose of gabapentinoids or we would actually omit them totally.
And is there a frailty adjustment?
Yeah. That we haven't got in Cerner, but we would do. I think elderly frail people are really do get very, very sleepy on gabapentinoids. So you've got to balance the risk of being sleepy and not being able to mobilise against the analgesic benefits.
And the ketamine, low-dose ketamine, which seems to be highly effective, but there is this question as whether part of the increase in post-operative delirium somehow relates to the use of ketamine. And maybe that's just because we're turning the hypoactive deliriums into hyperactive deliriums.
Well, and are you talking about continuous infusions of ketamines or dosing?
Go at it, guys.
Yeah, well, we do use ketamine in my institute. I think ketamine is a great drug because there's not many drugs that get you off opiates. And ketamine is one of those which is truly opioid sparing. And we use both as either a 0.5 milligram per kilogram loading dose or an infusion to continue into the post-operative period. We do use very low doses. The doses you need by infusion are literally 10 to 20 milligrams an hour, no more. Any more, I think you just get increased delirium and the problems with ketamine. However, I do have words of caution because I do see the higher delirium rate with ketamine. But where ketamine really wins in the US is we have a very high proportion of people who have opioid tolerance coming in for surgery. And I think that's the patient group that you get a real win in. Because without the ketamine as a base, you're using very high doses of opioids if you can't get complete analgesia with local anaesthetic techniques.
My colleagues who specialise in this area and do research in this area tell me that one of the interesting things about ketamine is if you have somebody who is addicted to a substance, when they're receiving ketamine, you can rationalise to them that then they don't want the opiate, and they'll say, "Oh, okay."
Yeah, I think we see that. The biggest problem
and
for us...
And there is research ongoing. That's not an anecdote. There's ongoing research program of reprogramming under ketamine.
Yeah, I mean, we're trying not to use ketamine in our enhanced recovery pathways because of the fact we have to take the patients to ICU post-operatively.
Really?
For if they're in an infusion, right?
If it's an infusion,
you can't go on the floor.
And it's rather strange that we can put patients on the floor with an epidural where you can get life-threatening hypotension, but you can't run very low-dose ketamine on the floor. Yeah. And this is, again, system challenges that we face getting enhanced recovery pathways up and running.
Can you have a morphine PCA on the floor?
You can have a morphine PCA on the floor, but you cannot have low-dose ketamine infusions because it's technically an anaesthetic drug, and that's all to do... That varies according to states, so we've looked into this in different states, and it is fascinating, just the rules that get thrown up.
So, apart from the Slido technology, which will put the questions up in a second that we can use to ask questions, we also have a microphone here today, so if anyone who's listening, like to ask a question, just put your hand up and get in here and ask Mike a question. Yeah, Mike Grocott, I think it is.
Mike Grocott, visiting the Top Med Talk stand.
Good morning, Mike.
Mike, lidocaine infusions, is that part of your repertoire, or do you avoid it?
It's interesting you said that because I presented yesterday here at ASA in the ASA session, and we talked a lot about all these alternatives. I spoke on epidurals, and what was interesting, I showed that in basically minimally invasive surgery, you don't need epidurals anymore. We've done the stress work on that. We've done the outcome work. There still doesn't mean so you can't use epidurals in laparoscopic work, because in Crohn's disease patients on high morphine intake, they can serve a role. But we had the backbone for minimally invasive surgery in Guildford as intrathecal opiates, so the equivalent of about 150 mics of Duromorph for here in the US. And with that, we found a 6 to 10-fold sparing of morphine downstream. However, to get to the point of lidocaine infusions, is we can't use that in my institute because there's a policies about the risk of post-operative respiratory depression, despite the fact that you've got the same risk as if you're having a PCA. So what we have done is we started using lidocaine infusions with low-dose dexmedetomidine for laparoscopic surgery, and the results have been really quite profound. if you can get your base of non-steroidals and acetaminophen in with IV lidocaine and low-dose dexmedetomidine, we're seeing the same results that we were getting with low-dose spinals with morphine.
In a full opioid avoidance.
Yeah, absolutely. So in our bariatric surgery now, we're literally, this Thursday, we're introducing a totally opioid-free pathway, no fentanyl induction, with basically lidocaine, low-dose dexmedetomidine.
And you just run intraoperatively.
We do. At UVA, they run post-operative lidocaine infusions. And Tracy Heidsick there has very good outcome data with that.
And do they have to go to the ICU there? Because I know that's another common barrier.
I think they've managed to get it to a high-level care unit, but I don't know, to be honest.
Yeah.
Again, we're trying to hopefully get a lidocaine infusions to some sort of post-operative unit.
Yeah. So I think there's another question from the floor, but Mike Grocot's going to act as a surrogate communicator.
Delightful lady here is microphone shy, but is very interested in the a little more flesh on the opioid minimisation, opioid avoidance following surgery. Is that right?
Which is a Slido question we have up here as well.
Yeah.
So how does opioid minimisation avoidance fit with enhanced recovery? And there's also, do you want to know how he does it? Because I
just want to know the protocol.
Okay.
Yeah. Well, I think it actually all starts with the pre-operative clinic. We now have an information sheet to get people to expect not to be totally pain-free. And going back to the PAQI paper, I think we could produce some very nice diagrams which we actually use in our pathways to talk about pain being giving good analgesia, but it's all about restoration of function and minimising side effects too. And so if patients realise they don't get out of bed immediately and they're expecting total analgesia, then that actually delays their recovery. So you've got to start with education. You've got to start in the pre-surgical unit giving the right loading doses, because IV acetaminophen here is very expensive. So we try and avoid that unless we give a top-up dose at the end of surgery when we've been going for 3 or 4 hours.
And Mike, afterwards, you'll be happy to share your recipes.
Oh, absolutely,
with people.
yeah. Absolutely.
The detail, no problem at all.
And then basically, if you've got a patient who's pain-free in the PACU, provided you maintain the multimodal analgesia, and the game changer in enhanced recovery is people are then drinking and eating after surgery. That's the game changer. So they're taking tablets, they're mobile, they're not just focused on a pain score lying in bed. Because they have actual control over their recovery, you'll find that they handle pain better. So it's multifaceted pain relief. There's psychological aspects as well, not just pain. But to give a good idea of what we presented yesterday in the ASA meeting, we talked about looking at pain per procedure and looking at wound pain and visceral pain. So visceral pain in laparoscopic surgery is going at 24 hours, whereas it's longer in open surgery. It depends if you've got surgical drains in or not. And then you've got the wounds and abdominal pain. And if you actually tackle those two pains slightly differently, I think you can reduce opiates further still. And that's why your primary selection of single block or catheter-based technique in local anaesthesia is important.
So we'll come out for another question on the floor in a second, but for those of you, I know we've got people listening elsewhere at Anesthesiology 2018 and around the world. We have listeners in up to 90 countries, so if you do want to post a question, we will take it here. If you go to Slido, slido.com, and you put in TMT ASA 18, that's TMT for Top Med Talk, ASA, where we are, 18, you'll be able to enter your questions and or vote on the questions that are there at the moment. So another question from the floor, Mike again.
So the base of your analgesic pyramid, as I understand it, is acetaminophen and non-steroidals. Do you do this, the alternating dosage, which quite a lot of people seem to be starting to do with sort of one at 3 hours, one at next 3 hours? I'm
trying to simplify it actually so that nurses can give medications in one go.
Yeah.
So, and in fact, if you use the COX-2s, you've got a longer time between doses anyway.
Do you let patients do it themselves?
We don't know. Again, it's interesting. In the UK, they were empowering patients to take the tablets, but here that doesn't seem to be allowable.
No, you can't even take a pill from a bottle.
So in other words, if you can send them home within 24 hours, they can take them for the next few days. But if you're in hospital, you're incapable of doing that.
Correct. Yes.
It's too unsafe to be in a highly supervised environment taking your own tablets. Got it. I'm all over that.
Let me ask one question, because this I hear is a common barrier that you have to get it scheduled. The NSAIDs scheduled instead of just PRN, because the nurses always will choose the narcotic or other medication.
Yeah, I think it's interesting because pain relief in the US has been reactive. Mm-hmm. So there's been very little use of basically prophylactic multimodal analgesia post-operative, and it's always been on a pain score.
Yeah.
So one of the biggest system fixes that we've had to do at VCU is, rather than treating mild, moderate, severe pain, is we basically just treat breakthrough pain now.
Yeah.
And that's what we reserve the stronger drugs for. If not, they just get regular multimodal analgesia. But the other interesting thing is, in the UK, you normally just schedule the analgesia. People get very worried here as if someone doesn't get their Tylenol 1 hour within a certain time.
Yeah.
And I think it really doesn't matter as long as you're getting it
on a regular,
between 4 to 8 hourly.
Yeah.
And so that creates a problem, because if patients are coming out of the OR later, people worry about the timing of the pills, and they start waking people up at 4 o'clock in the morning. So I'm trying to encourage a sensible approach where we allow our patients to rest and sleep at night, and the dosing is last thing at night.
Do you use suppositories here, which is very...
No, we don't. And I'm actually not a fan of suppositories unless it's Voltarol in the operating room.
Gotcha. Yeah. So we're actually running our poll today. Yesterday we ran a poll about adoption of enhanced recovery, and the view was that the majority are either using enhanced recovery for all their patients or most of their patients. Today we put up a question: in elective inpatient surgery patients on an enhanced recovery pathway, I use scheduled oral acetaminophen / paracetamol tablets, this is, on either all my patients, the vast majority of my patients, on a few patients, no patients, or I don't understand the question. Now, interestingly, so far 14% don't understand the question, which is, there we go. But where do you stand on that spectrum? Or everyone? Are there any contraindications at all?
Well, the FDA has also complicated things over here, because they're saying that you shouldn't have more than 3 grams in 24 hours, despite the fact that the rest of the world is 4 grams. Yeah. And it doesn't quite make sense, because the actual mechanism of toxicity of paracetamol is all to do with actual loading, not your regular dosing. Yeah. And it's more than 4 grams in 24 hours. I appreciate that if you've got liver disease, then you would want to be more cautious, and we were in our liver resections back in the UK. But the other issue, I think...
So you're a vast majority, which is...
I am a vast majority. The thing that's complicated our use of acetaminophen over here is a lot of the surgeons have favourites where they use basically a 3-2-5 combination of acetaminophen with some sort of opioid, like Percocet and things. And so you can't get the full benefit of the acetaminophen, because you can't give that 1 gram 6 hourly.
I assume you can't give 2 grams here then, which is morphine equivalent, basically, according to some of the studies.
That's right. Yeah, the 2 gram loading dose that we... Well, in fact, we had to bow out of that in the UK as well due to pharmacy. Yeah. They didn't like us doing that. But in France, they still do that.
Yeah, 2 grams, and it apparently is equipotent with morphine in many patients.
Yeah. It was a huge teaching component for us to talk to the nurses to say, give the Tylenol, don't give the narcotic. Yeah.
Tylenol is a trade name.
Oh, excuse me, acetaminophen.
Acetaminophen, and for them listing in a lot of the world, paracetamol.
Yes.
But the other challenge has been getting non-steroidals accepted by the surgeons. Okay.
Yeah.
Everyone thinks they're the devil's work and cause everyone to go into kidney failure.
Right.
But I think what we've got is now, all they're worried about bleeding or bone healing. And yet you've got huge systems like in the UK where everyone gets ibuprofen afterwards, whether they get hip and knee surgery or whether they get colorectal surgery.
With very, very few. So we don't believe in the anastomotic leak story, we don't believe in the bone healing story, we don't believe in the AK... Well, we do believe the AKI story.
I do believe in AKI, and I do think we need to be cautious.
Patients.
Exactly. But if you're bringing your patient in hydrated, having minimally invasive surgery, then we might not give non-steroidals on table to certain patients who've got a raised creatinine. But certainly, if they're good to go at 16 hours, then we would introduce them.
So we actually brought you over here, Meg, which has been fantastic.
It has, yes.
So we actually brought you over here to talk a little bit about...
anemia.
Oh, yes, okay.
Yeah. Well, no, so I saw your presentation at the American Society for Enhanced Recovery on Friday, and I think that this is so an important topic, a hot topic that many anesthesia providers are talking about now, and really important about changing practice.
That was a really great meeting, by the way. I mean, you had everyone there, didn't you? Dan Sessler, Chris Wu, Henrik Kellett, all those people just talking. It was a very good meeting.
Yeah, in the same room. I mean, yeah, it was great. It was all the big names there. But I was just looking at some of the slides that you were talking about, and there was one particular study that you said changed your practice and how you transfuse patients now.
Yeah, so basically I talked about preoperative anemia and setting up a clinic. We did that in the UK, and I'm pleased to say at VCU now, in the last year, we have set up a full preoperative optimisation clinic and trying to get this idea of clearing for surgery out of the window. It's all about optimising, because at the end of the day, cardiac events are not as high as we think, although there's some evidence you get this type 3 MIMS. Yeah. But it's more important to optimise things like haemoglobin, nutrition, avoid dehydration. And anemia is one of the biggest risk factors for surgery. We know that about a third of people going into major surgery are anemic. And so we can do something about it now before surgery. And so what I talked through was the
Sorry
fact
to interrupt, Mike, just so people focus on that point. So 1 in 3 people going in for major surgery are anemic. They have an inadequate level of hemoglobin.
Yeah, and that's large data. So that I'm quoting the USOS study of 47,000 patients across Europe and the study here in the USA. So we're not doing a good job, really, of screening people for anemia.
I think that someone wants to come in.
So, Mike, so I'm a big fan of anemia clinics, but we really sold ours on the basis that we could reduce transfusion, and therefore the business case is very straightforward. We've got lots of associative data saying that anemia is associated with a bad outcome, but do we truly yet know that what we're doing in our anemia clinics is improving outcome?
I think that's a good question, because we see there's a variable response. So basically the framework we use, anemia is very complicated, and you also have to exclude other causes, particularly cancer, if you're looking at elective orthopaedic surgery. But in most patients coming for urgent surgery, they've either got iron deficiency anemia from the problem that they're facing for surgery, or they've got anemia of chronic disease, or a mixture of both. And the good news is that we now have a fix, which is intravenous iron, which overcomes the problem of absorbing enough iron from the gut, either if you're losing blood, or if you've got anemia of chronic disease where you've got hepcidin activation, which blocks the iron going to your marrow and being absorbed. So you've got a functional anemia.
So can we just pause there for a second, because traditionally many of us would have grown up with the iron tablet challenge.
Correct, yeah.
Unpleasant to take for very many people. Yeah. Complicated dosing, because it's not as simple as take a lot of them, you absorb a lot more iron, and can take months and years to fix anemia. Is that
That's right, yeah.
Whereas the intravenous iron, there were challenges with anaphylaxis, etc. Now you can drop a bag of iron, and you can fix the problem.
So basically the newer iron formulations, iron sucrose, iron carboxymelose, you can give between 300 to 1 gram in a sitting. And most people, if you look at there's online calculators to work out iron deficiency.
How about a year? You can fix a year's worth of deficiency.
Absolutely. So if you've got a hemoglobin 11, your average iron deficit is 1.5 grams ish, just to give people an idea. So you can actually drop that into a patient in 20 minutes and wait for their marrow to respond. And you get a reticulocytosis around about 3 to 5 days. If people respond well, they respond by about 1 gram a week, is what we've seen in our work both back in the UK and here in the US. But you do get non-responders too, so it's not a total fix.
There are a lot of people, though, that will say that they have issues with giving IV iron.
I had the same challenges at VCU. Everyone thought, well, why am I, as an anaesthesiologist, giving IV iron? But obviously I've boarded in internal medicine as well, so I feel more comfortable about it. But I use a slide to show the risks of blood transfusion in 1 single unit blood transfusion, and then the risk of an iron infusion, which is less than 10 in a million. There's a lot of nanoparticle reactions, so a lot of people do actually feel they're having a reaction. But if you give them steroids and antihistamines beforehand, it's a lot better tolerated.
I'm not tracking here. So, Desiree, did you say there are certain practitioners who are nervous about injecting iron?
Yes.
They're happy to inject heroin, human donor blood. Is that right? But they've got the iron.
Yeah, they have issues with it, and they're worried about the reactions.
Yeah. Okay. So the data I presented is from the US. Is you've got a risk of a serious blood transfusion, still about 1 in 333.
Yeah, it was profound when you said that.
Even with cross-matched blood, you can get a delayed transfusion reaction.
Yeah.
at about 48 hours, and that's still about 1 in 500 to 600. It's quite surprising. So it's a low-grade reaction, but it's still there.
Yeah.
Then you've got all the other bad things that can happen if you've got cancer, increased surgical site infection, or risk of sepsis. We know from the anaesthesia and analgesia paper last year, the review, showing that it was about 9.6-fold risk for sepsis and deep wound infection too. There's still a signal there.
Yeah. So when you put the slide up, that was what struck me, is that you had all these things, all these issues with blood, and
and yet people are still worried about an iron infusion.
And they're still worried about an iron infusion.
And I think that's a reflection of the way that we're very siloed in the US of whose problem is it. If you're giving the iron and there's a problem, you're the one that might get litigated against.
Yeah.
And it leads back to the whole movement of perioperative medicine and why perioperative medicine is important, because whose risk is it? It's the patient's risk.
Yeah.
And yet we're having people bow out of doing interventions because they're worried about the risk. And yesterday I talked in the pain meeting about epidural and risk, because if you are doing an epidural and saving someone having a pneumonia post-operatively, that has a very significant downstream effect on their life expectancy and outcome. Yeah. And the risk of an epidural might be worth taking, but the patient needs to know it's not just the risk of the procedure, it's the risk of the benefit. If you don't get the benefit, what are the alternatives? And it's the same with iron.
Yep.
So the data on orthopedics is really profound. I presented a paper from the American Medical Association which showed that transfusion rates were up to 25% in elective hip and knee surgery, despite the fact that there's only a 3% hemorrhage rate. So we're almost correcting long-standing anemia with acute blood transfusion just because it suits us at the time of surgery.
Get stuck in a number and I have to transfuse.
Yeah, and again, there was hard data at 5 years. This is a long-term outcome data, which really has changed my practice, because I didn't think blood was that bad. But it showed that the risk of anemia is there, but also the risk of a single unit blood transfusion at 5 years had a mortality impact of 10%. And that was where they case matched the patients and used regression analysis. So I think the data was quite powerful.
Yeah. So we on Top Mid Talk, Desiree in particular, you've recorded a number of interviews about anemia. Are you getting any mixed messages? I know we're probably interviewing enthusiasts, but
we are. No, I mean this is pretty common. We talked to Bobby Jean Schweitzer and Lori Heller at EBPOM a couple weeks ago, and we were talking specifically about setting up pre-optimization clinics and utilizing anemia. But no, I mean it's all everyone's kind of jumping on board the people we're talking to.
So it does seem as though the improvements in the utility safety of intravenous iron is the big stepping point, because the EPO story turned out to be a little bit disappointing and harder to deliver. But the IV iron, obviously we always got to proceed with caution. Correct, but just on the transfusion avoidance and the relative ease of use, it looks as though it might be a significant tipping point.
That's right, and really what we should be doing is screening the patient as soon as they have that decision for surgery.
Yeah.
And then I showed on Friday that we need all the hematinics and iron studies really to be safe. Yeah. But we should be giving that first iron infusion as soon as the patient knows they're going for surgery.
So are you cancelling? I'm sorry, Monty. Are you cancelling cases? And how do you have that conversation with your surgeons? Because it's a huge one.
Steve Cates, who's the chair at VCU for orthopedics, who is also on the HRQ grant, rolling out ERAS across the ASA, he has got hard stops for everything. So we have a hard stop for anemia having hip and knee surgery. No one goes for surgery who is anemic, unless they've got an underlying condition that we've tried to correct and we cannot optimise any further. So whereas urgent surgery for cancer is slightly different because you've got a time base there.
I mean, we don't have time for it today, but we'll come back to another time, is the quite shocking data that's come out of universities who've looked at their students more closely, particularly young girls, female students, particularly exercising female students, particularly exercising vegetarian or vegan female students, and how common anemia is and its association with things like depression and fatigue. So, I'm worried about that for my own girls and encourage them to have a closer look at it.
I think it's been a revelation to me. I think we need to look at a population base and see how we can fix anemia in general. If you look at the world population, it's even more impactful because of the high incidence of other diseases. And so it is a fix we need to look at.
And have a conversation that women shouldn't have to live have a lower threshold.
Well, that's right. So half of women with a hemoglobin of 12 are iron deficient. And the other thing we talked about is the fact that giving pre-operative iron is a good thing because it helps recovery. And women are particularly at risk because, we know there's some work to show that blood loss is pretty consistent between surgery, and because women have a lower starting blood volume, it has a bigger effect on them, obviously, so they end up with a lower starting hemoglobin, but also they're iron deficient, so they can't make it up post-operatively so quickly.
Well, we're going to have to wrap there, Mike. I'm going to ask you to knock off one of our Slido questions.
Yes.
Should every patient be scheduled for ERAS, Enhanced Recovery After Surgery?
Undoubtedly, yes, because if you adopt the principles, it's basically evidence-based perioperative medicine.
No doubt about it at all. What a fantastic thing to close on. Mike, Scott, thank you very much indeed for joining us. Desiree and everyone here at Anesthesiology 2018, thank you for the audience for joining in and facilitating the questions there. We'll be back. So thank you very much for the applause. We will be back to you soon. Don't forget to log on to topmedtalk.com. Don't forget to subscribe. You have a chance, if you do subscribe and you're at the ASA, to win our fantastic Marshall Retro speaker, which is much coveted. And also, when you subscribe, you will have the access to our back catalogue of now over 300 fantastic podcasts, all completely free if you subscribe with us today. Thanks a lot. See you soon. Top Med Talk.